Welcome back to Therapeutics. In this block, we'll look at pulmonary infections. Our focus is primarily going to be on bacterial pneumonias, and we'll spend a little time reviewing tuberculosis. The rest of the elements here we'll briefly kind of allude to more or less in passing. So as we look at pulmonary infectious disease management, I'm encouraging you to think back on how we have looked at antibiotic use, how we make empiric decisions, how we use antibiogram to help in those empiric decisions, as well as trying to determine what it is about the patient in front of us that suggests the likelihood of bacterial pneumonia, for example, their history, that have they had exposures to healthcare system or not. Are they smokers or not? Are they an aspiration risk? All of these are going to be variables that we're going to think of. And then looking at the potential pathogens we think are going to be likely for the patient in front of us and the antibiogram from the setting where the patient comes from. So let's sort of move forward here. So as we look at pneumonia, particularly bacterial pneumonia, keep in mind the types of pneumonias per the 2016 guidelines really differentiate community-acquired pneumonia from hospital-acquired pneumonia and ventilator-associated pneumonia. So let's walk through these three. The fourth one that's listed here is the older term healthcare-associated pneumonia that is not reflected in the 2016 guidelines. But let's go through first the first three. So community-acquired pneumonia is considered an acute infection of the pulmonary parenchyma accompanied by an acute infiltrate on chest X-ray or auscultatory findings. And the issue, I think, in practice is we then think, okay, this pneumonia was acquired in the community. We are then going to look at those folks in varying degrees. We're going to look at modifying risk factors in those community-acquired pneumonias. We'd consider an uncomplicated community-acquired pneumonia patient is a patient who hasn't had a hospitalization, hasn't received IV antibiotics in the prior month or so, and is not a frequent flyer in healthcare settings, not on dialysis in a dialysis clinic, not in a nursing home, not in a repeated attendance at a hospital clinics, those kinds of things. If they have any of those elements, then we're going to consider them community-acquired still for pneumonia, but we're going to look at their risks for certain pathogens as being higher, and we're going to look at those modifying factors affecting how we approach their community-acquired pneumonia. So we'll walk through that. But a community-acquired pneumonia is anybody who acquires their pneumonia from the community. Hospital-acquired pneumonia is defined as patients who have acquired their pneumonia while in the hospital for at least 48 hours. So if somebody comes in the hospital and within 24 hours they present with what looks like pneumonia, officially we still define those as community-acquired pneumonia because there's a lag time between when they acquired it and when they present with their symptomatology. Ventilator-associated pneumonia is a subset of hospital-acquired pneumonia, and ventilator pneumonia arises more than 48 hours after the patient's been intubated and on a ventilator. And as we alluded to, the older term healthcare-associated pneumonia is no longer used, but we'd consider those patients community-acquired pneumonia with modifying risk factors. So, as we alluded to, community-acquired pneumonia, uncomplicated patients, haven't had hospitalizations, not long-term care residents, all of those. But if they have those elements, we look at those as modifiers in their community-acquired pneumonia situation. Patients who present with community-acquired pneumonia typically will present with fever or rigors, cough with or without sputum, chest discomfort, dyspnea, often with fatigue. And keep in mind that older patients often present in a somewhat atypical kind of way. What is going to be predictive of a more complicated course? Well, older patients are going to be more problematic. Comorbid states are going to be more problematic. Very high fevers if they've had bacteremia, altered mental status if they're immunosuppressed. or if they have other risk factors for other pathogens. For example, hospitalization means maybe their MRSA risk is greater, or if they've had aspiration, you're worried about oral anaerobes, those kinds of things. So we need to kind of modify our approach based on the kind of patient that we're going to see. Um, so let's look at the published in early October 2019 the latest guidelines from the Infectious Disease Society of America for community-acquired pneumonia. And these guidelines, just newly published in late 2019, are for the most part similar to earlier guidelines with a couple of key exceptions, and at least one recommendation that I'll tell you causes a number of us in clinical practice a bit of heartburn. And I'll sort of, when I get to that, I'll share it and share with you what is probably the more controversial approach to it. So the one question that's critical when we look at folks who have community-acquired pneumonia is, should you use the predictive rule whether or not a patient should be inpatient or outpatient? And the answer and the recommendations are yes, we should. There are two scoring tools. The new guidelines do recommend using the pneumonia severity index over the CURB 65. Here's the issue. The pneumonia severity index will provide a more precise prediction of what someone's risks are than the older CURB 65 scoring system will about whether someone should be an inpatient or an outpatient. But the bottom line is that the pneumonia severity index is a fairly complicated tool to use in that there are a number of elements. And so unless that gets integrated in some easy way in the assessment process, it's not likely to be consistently used by practitioners. And the CURB 65 is a more simplified tool and still offers good predictive value. So the bottom line, I think, is that most clinicians probably would still use the CURB 65. If you had access to the pneumonia severity index and you could integrate that into your practice pretty easily, then yes, I think absolutely that would be the preferred option because it is more precise, but it also is more cumbersome to use. So let's look at outpatient management of community-acquired pneumonia from the new guidelines. And we're not going to hit everything in these new guidelines, but should we get cultures and gram stain? And the recommendations from the new guidelines are that for outpatient, likely outpatient management based on a CURB score or other assessment of severity, if you're going to manage them in the outpatient, it probably doesn't offer you a lot of utility to get a sputum gram stain and sputum culture. The other issues that they look at are both gram stain or blood cultures, not recommended because they typically are not going to change what you're going to do for treating. So what are the likely pathogens you need to think about for community-acquired pneumonia? Well, for community-acquired pneumonia, depending on the patient, the big things we think about are, first of all, if you would even have gotten a culture, which is no longer not recommended in community-acquired pneumonia that's an outpatient management, we typically would see that about half the cases you're not going to get anything for growing out of your sputum. And then the most common pathogens are going to be atypicals like mycoplasma pneumonia. You're also going to worry about H. flu, chlamydia, Legionella, strep pneumo. All of these are going to be sort of an issue. So those are sort of things to think about as pathogens. Now, remember we talked about community-acquired pneumonia where there are other modifying factors that make you think I need to cover more or different things. So let's look at the bottom half of this table on the left. If you've got somebody with a history of alcoholism or aspiration, you need to worry about both strep pneumo, but also oral anaerobes and more gram-negative bacilli like Klebsiella. You're worried about aspiration risk in particular. If it's a nursing home resident, you're worried about strep pneumo, H. flu, you're worried about some gram-negative bacilli, and you start to worry about MRSA and Staph aureus in community-acquired pneumonia. If they have COPD, we're worried about strep pneumo, H flu, Moraxella catarrhalis. If they've had influenza, similar pathogens, H flu, Staph aureus, though, and also strep pneumo. If they've had exposure to mist or water, showers, contamination, we want to put Legionella in that mix. If they have poor oral hygiene, you're thinking about their oral anaerobes. If they have HIV, advanced HIV, you're thinking about immunocompromised states where you're worried about mycobacterium, you're worried about TB, you're worried about pneumocystis. So all of those are modifiers that will affect our decision to treat. So back to the guidelines from the Infectious Disease Society of America for community-acquired pneumonia. If someone doesn't have comorbidities, their recommendation, and no risk really for MRSA or Pseudomonas, they haven't been in the hospital recently, for example, or a nursing home, their standard regimens are amoxicillin or doxycycline or macrolides. Let's walk through those for a minute. Their first recommendation for amoxicillin, which they gave a pretty strong recommendation for, gives most of us clinicians heartburn. Why is that? Amoxicillin is great for strep pneumo. It is great for a number of the other pathogens. But keep in mind, what is about a third of the pathogens in uncomplicated community-acquired pneumonia are atypicals. We're worried about all of the classic atypical agents for which amoxicillin does not cover. And so of all of the factors in these guidelines, I think a lot of clinicians have a lot of heartburn over this. And so as such, when I sort of did a quick survey of clinicians I work with at the hospital I'm at, both in the ICU and in the general medicine floors, and with an ID specialist about this, everyone was a bit alarmed that they recommended no atypical coverage as first-line therapy. The other two choices that they recommend do have atypical coverage. Doxycycline certainly does, and doxycycline is a reasonable choice. The other choice they say are macrolides, which make a lot of sense, and they recommend macrolides, azithromycin particularly, will make sense for patients as long as our strep pneumo coverage resistance in our particular region is not problematic. And so strep pneumo is probably the one that's going to cause the most severe community-acquired pneumonia, and so we really do want strep pneumo coverage. And if your amoxicillin track record in your region based on antibiogram is not great for strep pneumo with azithromycin, then that might not be a great empiric choice. What about the duration of recommendation? Typically, they look at 5 days or so after the patient is clinically stable. So usually outpatient management, 5 to 7 days of therapy is reasonable. A 5 to 7 day course of doxycycline, a 5 to 7 day course of azithromycin, or a 5 to 7 day course of amoxicillin. But you do want to check in with the patient who's outpatient, in the next day, the next 2 days. Are their symptoms better? And keep in mind, if you've chosen amoxicillin, you're not covering atypicals, and so that's going to be an important issue. What about inpatient community-acquired pneumonia? What is the recommendations? So the recommendations from the Infectious Disease Society of America for community-acquired pneumonia in 2019, October 2019, look first at determining whether or not you've got severe community-acquired pneumonia. These are the patients who are going to be hospitalized. So what's their respiratory rate? Is there confusion or not? Is there uremia? Other elements that you kind of want to look at that are going to be indicators for the severity of their community-acquired pneumonia. But all these folks are being hospitalized. So this table, let's walk through this a bit. So first of all, for initial treatment for community-acquired pneumonia, we're going to look at whether or not they're more or less severe. And if they're more severe with the symptomatology, we're going to be more aggressive. And typically, the classic regimen is going to be a beta-lactam plus a macrolide or a beta-lactam plus a respiratory fluoroquinolone. For non-severe, you're going to use a beta-lactam and a macrolide or or alone a respiratory fluoroquinolone. Here's what the difference between those two groups are. The first, for the non-severe inpatient, you're going to cover atypicals with a macrolide or respiratory fluoroquinolone And the beta-lactam is going to cover strep pneumo, and strep pneumo is also going to be covered by the respiratory fluoroquinolone. Most clinicians these days will go with the beta-lactam and azithromycin. Usually it's ceftriaxone plus azithromycin. That's sort of standard care for most folks coming in the hospital with community-acquired pneumonia when they're a candidate for it. You're going to cover strep pneumo, you're going to cover atypicals with your macrolide, and the beta-lactam is going to give you double coverage for strep pneumo in case the azithromycin is not a problem. The respiratory fluoroquinolone is an alternative. Levaquin, for example, is classically what most folks are going to use, not ciprofloxacin. Levaquin because it covers strep pneumo as well as atypicals. The problems with the respiratory fluoroquinolone and why a lot of clinicians and a lot of guidelines are moving away from respiratory fluoroquinolones as first line are resistance patterns with fluoroquinolones and adverse effect profiles, including prolonged QT, and the other issues are tendon rupture and drug interactions with the fluoroquinolones. Now, keep in mind macrolides like azithro also prolong QT, so that's also a potential issue. When it's more severe, they're looking at really a similar beta-lactam plus a macrolide or a beta-lactam plus a fluoroquinolone, really similar to the non-severe cases, except you're sort of upping the ante with strep pneumo coverage. So that's sort of the standard approach. Now, look across the top for other modifying factors here. What if they have had prior methicillin-resistant Staph aureus or Pseudomonas risks? Those include patients who have either been hospitalized, and so MRSA would be an issue, or patients who have been hospitalized and ventilated or respiratory manipulation for which Pseudomonas would be an issue. So in those patients, you want to add MRSA coverage or consider adding MRSA coverage. And the other element we'll talk about in the next couple of slides when you're thinking of MRSA coverage is you're looking at maybe getting a nasal PCR for MRSA at the onset, at admission, so that if you start vancomycin, for example, from MRSA coverage to your regimen, after a couple of days, if they're doing well and their PCR screen is negative, you can peel off or strip away the vancomycin. So adding MRSA coverage if they're a MRSA risk is great, but if you're armed with that PCR early on, you're at a better position to then scale back or stop the vancomycin in a day or two when you look at an antimicrobial streamlining. Okay, so that's community-acquired pneumonia sort of in a nutshell. For hospital-acquired and ventilator-associated pneumonia, there are different guidelines. There are older 2016 guidelines here. Basically, their recommendations is that you will get, in these patients in particular, but you could even say for the admitted patient for community-acquired pneumonia, it may make sense if they're more severe that you would have gotten cultures and you would have gotten sputum culture and blood cultures done in that severe community-acquired pneumonia patient. And definitely in hospital-acquired pneumonia patients, you want to get sort of pan cultures. You want to look at that is going to help you make the decisions you need to make ongoing. The other issue is you probably do want to screen them for any risk for MRSA or Pseudomonas and make sure that those are kind of in your sort of initial empiric coverage before you peel things away. If folks are overwhelmingly septic with their pneumonia, either community-acquired pneumonia or hospital-associated or ventilator-associated pneumonia, then you need to look at all of the sepsis 1-hour bundle recommendations that we also talked about in infectious disease. So initially, immediate lactate levels, blood cultures, broad-spectrum antibiotics, rapid fluid boluses, and vasopressors. All of that are going to be sort of important elements to consider as we look at managing those patients sort of acutely. With hospital-acquired pneumonia, what we're aiming at are, keep in mind that you get all these cultures, half the time you're still going to not get anything like we saw with community-acquired pneumonia. But when you get cultures, you want to cover Staph aureus and Pseudomonas empirically, and then other gram negatives as are listed here. And again, sort of the modifying things, if anybody has had any respiratory manipulation at all, you want to make sure you have Pseudomonas coverage, and Staph aureus is endemic in hospital situations, so you want to cover probably for that. And then sort of other sort of factors that are listed here sort of as well. So based on the guidelines, what are the recommendations for empirically treated hospital-acquired pneumonia when someone isn't ventilated? For the most part, they're looking at getting adequate broad coverage as you normally would, and then coverage for MRSA, and perhaps coverage also for Pseudomonas. And so this sort of outlines getting MRSA coverage, and this graphic in the 2016 guidelines sort of recommend getting pseudomonal coverage, particularly folks who might have a higher risk factor for that. The other issues would be, at what point would you discontinue antibiotics after they've done well? And for hospital-acquired pneumonia and even ventilator-acquired pneumonia, we're looking at a 7-day course of therapy at the very least, and probably going out to 10 and sometimes 14 days, but certainly 7 days after you achieve stability. So what agents sort of make sense? Well, in hospital-acquired pneumonia, what I see clinicians most often go with is Pip/Tazo. We're worried about covering Pseudomonas. Usually Pip/Tazo does well, but you want to make sure you're picking another antibiotic that covers Pseudomonas. So ceftazidime could, although we don't use ceftazidime that much anymore. Cefepime covers well, or the carbapenems do, but most settings like will have a restriction on carbapenems like meropenem or imipenem as well. For MRSA coverage, if there's a risk, in most patients who have hospital-acquired pneumonia are going to be empirically treated with vancomycin or linezolid. And then we're only going to add a second anti-pseudomonal if we think that there's a very high risk for Pseudomonas as a risk factor. They've had consistent IV antibiotics in the prior 90 days, which could have sort of posed a risk for resistant Pseudomonas. But for the most part, adding a second anti-Pseudomonal is not often routinely used in settings where patients are reasonably otherwise stable. In ventilator-associated pneumonia, you definitely do want to consider anti-Pseudomonal coverage, at least one agent, and maybe you've got a stronger argument in those cases because Pseudomonas is more likely a player at adding a second anti-Pseudomonal. But the problem is that the choices for a second anti-Pseudomonal really are limited to fluoroquinolones in most patients. Maybe as Trianem, which doesn't really, is somewhat limited, adding that to Pip/Tazo, for example. Aminoglycosides are really problematic in any patient these days because typically we worry about nephrotoxicity, but also dosing it for someone who doesn't have really good kidney function to start with is also problematic. You want to look also at any patient, hospital-associated pneumonia, ventilator-associated pneumonia, even community-acquired pneumonia, who's at multi-drug resistance. Risk for that. And those are folks who have prior antibiotics, recent hospitalizations, septic shock when they first got sort of diagnosed. And those patients, we're going to sort of look at more broader empiric coverage. But keep in mind, if you're doing a PCR for MRSA, as with your initial blood cultures before you start, you may be able to peel back your MRSA coverage if that's negative and the cultures come back negative. Okay?
Let's spend a few minutes talking about COVID and its management. It has evolved certainly since COVID was first identified in late 2019, and we began with therapeutic options in early 2020. Things have evolved. Early on, we were managing patients who had COVID pre-vaccine availability. We managed folks the best we knew, and some of that data included things that we look back on now and say, well, gee, there really wasn't data for that, and we don't do that anymore. particularly including things like hydroxychloroquine, were pretty commonly used in the first few months to half a year or so when we were trying to manage COVID pandemic in acute care particularly. Let's look here at some of the big places you'd want to look and some of the big themes with COVID-19 therapeutics. One is the vaccine, and you should always go to the CDC's website for the latest update in the recommendations for COVID vaccine. As of September 2022, there is now a bivalent vaccine booster available and for patients who are eligible, which is usually most patients over the age of 12, depending, or 18, depending if you're talking about the Pfizer booster or the Moderna booster. A little bit more on that in the vaccine section. But I encourage you also, when you're questioning or wondering where is a good place to get the latest information about COVID therapeutics, it's the Center for Disease Control website, cdc.gov. As you look through, they also have a nice link to updates and guidelines, and these summarize guidelines for you of whatever sort of the latest guidelines are. These guidelines were accessed on September 10th, 2022, but you'd expect that you'd see, so here as of that time, they told you the latest update was in August of 2022, and they tell you, and they kind of time when the new updates come through, so you'll know if you're dealing with current information, and you'll know whether or not, hey, I already knew this because I had looked at this at that time. That's helpful. What some of the key features you'll find when you look at these are the role of monoclonal antibodies, which there is a role, but it's a somewhat limited role of when we use monoclonal antibodies in COVID. And a lot has to do with as the variants have changed in COVID, we see that the monoclonal antibodies that initially came to market for COVID were for variants and targets on COVID that were, or spike proteins or something else that's no longer a common modality now that's not, or it's not effective because the antibody is not directed against something that's in the current strain of COVID. There'll be special considerations for individuals who are immunocompromised. Those patients include severely immunocompromised patients like folks who are on immunosuppressants for transplant medicine, patients who are undergoing chemotherapy. And then for some patients, more immunocompromised than others are, for example, chemotherapy patients who are being treated for B-cell lymphomas, where we give a drug called rituximab, which kind of wipes out their B cells that make antibodies. So those individuals particularly are going to be candidates for passive immunity with antibodies. And if they've got rituximab, they probably won't mount an immune response, an active immune response with the current vaccine for at least a year after their window of rituximab has stopped. So we'll talk more about that as the year goes on, but you need to think about if it's an immunocompromised patient, the public health measures of keeping patients away from crowds, using masks, social distancing, the standard public health measures we've used are recommended for everyone, but particularly those who are immunocompromised. And then the role for specific modalities that are maybe monoclonal antibodies, passive immunity for those individuals is helpful. They also update guidelines for children. You can look at those more specifically. They will give you other recommendations as time goes on for both non-hospitalized and hospitalized children and non-hospitalized and hospitalized adults. They will give recommendations also for preventing infection in specific cohorts, what the latest public health data is or is not. Additionally, they will talk about hospitalized patient and community patients who don't need to be hospitalized with guidelines. They also will sort of refer you to the treatment modalities, one of which we'll talk about in a minute, Paxlovid, for the outpatient management of folks who are at risk for severe complications with COVID. And a drug like Paxlovid has many, many drug interactions you need to be aware of. And so many times we have to stop therapy or interrupt therapy while patients are on that modality. This slide sort of refers to that, not a focus right now for you to memorize all of this, but to have an awareness of it so that when we go back and talk about these issues later on in pulmonary, you'll have a context to address them. One of the nice things that the summary slides give us in the CDC is a way to consider how to manage therapies in non-hospitalized adults with COVID and hospitalized adults. And they give you sort of updated charts, which get updated, sometimes weekly, sometimes every couple of months, depending on what changes have happened. But in the non-hospitalized patient and the hospitalized patients, we really pay a lot of attention in COVID about whether or not patients require supplemental oxygen or not. And if they don't, those are not as severely affected patients. Whereas if we have patients who have been recently discharged from the hospital, whether or not they have oxygen need or supplemental oxygen or not will sort of dictate the continuation of their in-hospital dexamethasone, for example, or their antiretroviral therapy. Okay, what you'll often find is that there is a role for folks who are high risk for using antiviral therapy early in the course of COVID. And one of the things you'll see here is Paxlovid is probably the standard therapy, or IV remdesivir is sometimes used if a patient doesn't have oral access, for example. And those, again, are pretty much limited to outpatients, particularly Paxlovid, limited to outpatients who have high risk for progressing to severe COVID. Those are folks usually who are immunocompromised or who have other comorbidities like heart disease, pulmonary disease, or are immunocompromised in any way. So, or older. So, important to kind of consider those factors, but more detail later in the year. And one of the last big areas in this chart go through the hospitalized management of patients with COVID. And this gets tweaked periodically as well. But the theme is generally that we see with COVID that patients, particularly who have a risk for developing COVID, significant outcomes with COVID, and particularly if they have some oxygen requirement, those patients are usually candidates for antiviral therapy. And in the hospital, the antiviral we currently use for COVID is remdesivir. It's usually given as either a 3 or a 5-day regimen for folks who usually have some significant risk associated with their COVID presentation or severe, often for folks who have some degree of oxygen requirement. And then we'll look at dexamethasone also. Dexamethasone is helpful, early to mid to later COVID because of the inflammatory response of COVID. So as we kind of alluded to in principles of antimicrobials, there are certain cases where we actually want to use dexamethasone or prednisone therapy, even though it's a little bit immunocompromising or immunosuppressing, because the risk for the inflammatory reaction to certain infections is greater than the potential downside of modest immunosuppression with these agents. So COVID, particularly in more severe COVID, dexamethasone is pretty much a standard of care. Finally, there are also guidelines in pediatrics, and again, it depends on the age. The cutoff in most use both for vaccines and for antivirals in COVID relate to ages 12 and above. 12 to 17 are often, if significant high risk, are candidates for Paxlovid or remdesivir, and ages 12 to 18 are also candidates for some of the vaccine requirements vary based on age, 5 to 12, 12 to 17, 17 and above, or 18 and above. For those who are aged under the age of 12, there's not as much data for the safety and efficacy of drugs like Paxlovid or remdesivir, and so we're waiting for more data to come to bear. Okay, so as you look at all of these antivirals, there's a lot of detail in these slide sets. Just kind of have an appreciation for the kind of antivirals, the specific. Is it a DNA virus? If we're talking about a herpes virus, we could look at drugs like acyclovir, valacyclovir, famciclovir. If we are looking at CMV, cytomegalovirus, a specific set of antivirals we'll use in that case, which don't cover other viral infections very well. And then we have specific treatments for Hep B, really, which aren't great, Hep C, which are great, and HIV, which are great, but not curative. And lastly, the big issues we think of with influenza, COVID, other antivirals, they have sort of specific drugs with specific niches and guidelines, and COVID specifically is an evolving science. So hopefully this is helpful for you to sort of picture the role of antivirals and more specificity and reinforcement throughout the year.
Let's now talk a little bit about tuberculosis. And TB is a major and thorny issue for a lot of patients. Let's look at some data on TB, both cases and the CDC's recommendations for management. So let's sort of spend a little time talking about tuberculosis. And the Center for Disease Control and the World Health Organization, both of those organizations have lots of ongoing, up-to-date information about managing tuberculosis. Tuberculosis is a problem in the United States. It is a greater problem worldwide. And so a lot of what we see for management of tuberculosis comes from recommendations from the World Health Organization and or in conjunction with those from the Center for Disease Control in Atlanta, Georgia. Here's a graphic from the Center for Disease Control about the rates of tuberculosis in the United States through 2017. And what you see here is that a moderate decline over the last decade or so, and we typically see a pattern that most of the cases of TB or at least originate in individuals from outside the United States migrating to the United States in one way, shape, or form, but we still see a number of U.S.-born individuals at risk for TB as well. And this mimics pretty closely the rates of patients who are immunocompromised. What we'll see, for example, is that in those patients who don't have good management of concurrent HIV, for example, that their rates of and risk for tuberculosis is much higher. The pathophysiology of TB, I'm not going to go into depth here. There is a graphic that sort of outlines the pathophysiology of tuberculosis. And really, this is more to do with what you'll learn in general medicine rather than in therapeutics per se. But I'd encourage you to spend a little time and walk through this slide on the slide deck just a bit to get a sense of the pathophysiology of tuberculosis. The diagnosis of TB, certainly we'll look at signs and symptoms, a patient history. All of those are critical in evaluating TB. Then you're going to look probably at a combination of both radiologic evidence and microbiology evidence as well. Keep in mind that we're going to look for microbiologically, while you want a culture for TB, keep in mind that tuberculosis is a very slow-growing pathogen. And so you may be waiting weeks for that sputum culture. And so typically what is critical, more so probably in TB than almost any other infectious disease, it is important to get a sputum smear and looking for acid-fast bacilli in that sputum smear. So that's particularly true because unlike many other bacterial infections where you can have that plate grow out pretty quickly in 24 to 48 hours, here with TB you're waiting many times weeks to see something grow out in that culture. And you really need to keep, if you have a suspicion for tuberculosis, you need to keep that patient isolated so they don't, particularly if it's active TB, isolated from other patients and other individuals so that they don't spread tuberculosis. And so in the hospital setting, if we rule somebody, we're in the process of ruling somebody out for TB, at the very least we're going to get sputum cultures. They're going to get them sent off, but it's going to be a while before we know those. At the very least, before we take them off of isolation precautions, we need to get multiple negative sputum smears for acid-fast bacilli and chest x-rays that are deemed to be negative, particularly for anybody who has any types of nonspecific signs, including cough, weight loss, and a history that could suggest tuberculosis exposure. Particularly concerning is cough with blood tinges in it. Now, there could be other etiologies for that, but we always are suspicious of TB in those kinds of cases. We also have, typically we'll see that's been used for many years in diagnosis, or at least in seeing folks who are exposed to TB, is to use a purified protein derivative of tuberculin called a PPD. It's a skin test that's classically done. And there's also blood tests now that are done that are less sensitive but have greater specificity for tuberculosis. And sometimes these blood tests are used in lieu of or in place of skin testing for PPD. The advantage is that you don't have to call the patient back or the individual back to look at reading that tuberculin test 48 hours later. You have the results available to you from the lab. So many settings, healthcare settings, for example, when they're ruling out TB for somebody, an employee, for example, they may elect to use one of these blood tests as an alternative to the older skin testing done for tuberculosis. In the next few slides, let's differentiate latent TB from active TB. When an individual is getting tested for exposure to TB but doesn't yet have fulminant tuberculosis, there are some considerations we look at, and we also look at the likelihood of a patient to be infected based on the nature of their contact and whether or not they have other comorbidities that increase their risk. So anything, for example, that would predispose to immunocompromised status, particularly HIV or immunosuppressive therapy, would really cause a high potential risk for their developing tuberculosis if they have latent TB, whereas patients with no other risk factors, not immunocompromised, are relatively low risk for developing ongoing tuberculosis. This chart lists the different agents available for treating tuberculosis. We have first-line agents and second-line agents. The first-line agents include isoniazid, rifampin, pyrazinamide, and ethambutol. Each of these are pretty commonly used for most common types of TB. Particularly isoniazid and rifampin are the most commonly used agents for latent TB and a patient who isn't otherwise have contraindications to their use. But pyrazinamide and ethambutol are often added on for active cases of TB when multi-drug therapy is really indicated. We'll talk more about these agents in a little bit, but as you think of these agents, isoniazid and rifampin are replete with drug interactions, isoniazid with some risk for peripheral neuropathies and liver injury, and then pyrazinamide and ethambutol each have their own unique adverse effects as well. The second-line agents has a longer list, and these are added on usually in drug-resistant tuberculosis by the ID service and or by the pulmonologist who might be managing TB at, for example, a TB clinic in conjunction with recommendations from the Center for Disease Control or from the Public Health Service. This slide reviews the recommendations from the Center for Disease Control for managing latent TB infections. And typically you'll see different regimens here, and some of these regimens are the once weekly or twice weekly regimens have to be what's called directly observed therapy regimens. And these regimens are really limited to patients who are directly observed to take their medication as indicated in front of them. And these might be caseworkers, for example, who are working, for example, with a homeless population or a population who otherwise are not necessarily reliable to take their medications exactly as prescribed. The more common regimens, though, that we'll see used for latent TB in non-complicated patients include either a combination of rifampin and isoniazid, or more often rifampin or isoniazid alone. The patients who have a drug susceptible tuberculosis but active tuberculosis have more aggressive regimens, and they typically involve 4-drug regimens with the 4 primary agents we've seen and talked about. And they may have an initial intensive phase for a window of time that might be in the range of 5 to 8 weeks or so, sometimes longer. And then they will go to a continuation phase of longer therapy with usually just isoniazid and rifampin. And these regimens are really recommended by the Center for Disease Control. The regimens occasionally change based on CDC recommendations and patterns for drug resistance if they develop. There's also concerns with some of these regimens, for example, with patients who have HIV, because some of the cocktails we use in managing HIV interact with, among other things, particularly rifampin. For patients who do have HIV, their approach to treating both a latent TB infection with their concurrent HIV or active TB is influenced by the regimens that they have for their HIV as well. And so typically we're going to look at avoiding rifampin in particular. So let's talk about some of the mainstream agents here and sort of get our hands around some of the things you think about when you use these drugs. First, isoniazid. Isoniazid's been around for a long time. It's a primary agent for both treatment and for prophylaxis of TB. And really, it's a first-line drug that should be really given to anybody for whom you have TB on your radar for someone who is a candidate for antituberculin therapy. It's highly selective. It's bactericidal to mycobacteria. There is some resistance, so we never use it alone. We use it in combination with other therapies, and most often it's used in combination with rifampin. It's only used for the treatment or prophylaxis of TB. It doesn't really have another indication, and we always take it in combination with something else. The adverse effects associated with isoniazid, the big ones are peripheral neuropathies, hepatotoxicity, and sometimes you'll see other things, some GI distress, sometimes some central nervous system effects like headache or dizziness or sedation, dry mouth, urinary retention, but those aren't common. What is common is peripheral neuropathy, and we can prevent peripheral neuropathy in most patients by also giving them pyridoxine or vitamin B6 at the same time. So the neuropathies that are associated with isoniazid are largely prevented by giving pyridoxine. So in clinical practice, you almost never see isoniazid used without pyridoxine. Almost universally, you'll see isoniazid and pyridoxine are 2 prescriptions that go hand in hand, always given together to prevent these peripheral neuropathies. The other concern is the risk for hepatotoxicity. Hepatotoxicity there have been deaths associated with it. The risks are greater as patients get older. Many years ago, or a number of years ago, we actually looked at limiting isoniazid to patients who were older because of this risk for hepatotoxicity. But in the last decade or so, the Center for Disease Control really has said, hey, even though there is this risk for hepatotoxicity and you should watch for it, look at liver function tests, it's usually reversible, and the benefit of isoniazid outweighs the risk if somebody has TB. And so they really recommend using isoniazid in patients unless you already have pre-existing severe liver injury already going on. Finally, there are a lot of drug interactions with isoniazid, and isoniazid is a drug that undergoes acylation, or is a type of chemical reaction. It's metabolized. And you may remember we talked about isoniazid earlier in the year when we talked about rapid acylators or slow acylators, and the risks were that rapid acylators, folks who metabolized it more quickly by their genetic predisposition to metabolize isoniazid, were more likely to have active metabolites that might be hepatotoxic. So some of the rates of metabolism of isoniazid is genetically determined, and that may predispose to either peripheral neuropathy or hepatotoxicity, depending on which, how they metabolize isoniazid. Doesn't mean it's going to happen, but it's probably correlated with their rates of metabolism. There are lots of interactions with isoniazid. You need to run a drug interaction management check as you start or stop isoniazid for any patient. Second drug we'll talk about is rifampin. And rifampin is not used just for tuberculosis. We see rifampin used usually in conjunction with other antibacterials for certain bacterial infections, Neisseria meningitidis, for example. So you'll see it used for other purposes and in addition to using it for tuberculosis. It inhibits bacterial DNA-dependent RNA polymerase, suppresses RNA synthesis. It's generally bacteriostatic by its very nature. Its kinetics, it's well absorbed in the stomach. The one thing you'll see, it's very distributed widely to tissue. It's eliminated by hepatic metabolism. Its metabolite turns bright orange. It will cause secretions, particularly urine, to look orange, tears to look orange. And so you need to warn patients that, hey, this is a drug that's going to make your urine look a different color. And patients would get very frightened if they didn't know that, because all of a sudden their urine is bright orange, almost red, and they think they're bleeding. So you want to make sure that they're aware of that. Therapeutically, we use rifampin for tuberculosis. It's also used for meningococcal carriers, highly effective for that. That's a protocol for somebody who's been exposed to meningococcal infection. And we use it also for leprosy. There are a number of things to think about with rifampin, but it's generally well tolerated. Occasionally hepatotoxic, that could be additive with isoniazid, but it's not, usually it's reversible, or it's usually seen, if it's going to be seen, with somebody who has already pre-existing liver disease. You do expect that red, orange urine, sweat, saliva, tears. It can stain soft contact lenses, so you want to be aware of that. It can cause some GI upset in some patients as well. Rifapentine is like rifampin-like drug. This is used for Mycobacterium avium intracellulare infections, also used for tuberculosis as an alternative to rifampin. It has it's a rifampin-like derivative. With rifampin and any of these rifampin derivatives, you need to run another drug interaction check. Of all of the medicines that are high inducers of drug metabolism, seeing much lower levels of the drugs that are substrates of the same enzyme systems, you really can see a dramatic drop in other drug levels. And so this is an issue for folks who are on anticonvulsant drugs for seizures. It's an issue for patients who are on medications for controlling or preventing pregnancy, estrogen-based products, lots of other things. You want to make sure you run a drug interaction check. So the drug interactions, as we alluded to, they accelerate metabolism of a number of other drugs. Rifapentine and rifabutin, related drugs, also the case. And keep in mind also that folks who are have advanced HIV are higher risk for tuberculosis. And so if you have somebody who has TB plus HIV, we're going to typically put them on standard protocols. We need to watch some of the HIV meds interacting with rifampin, rifapentine, or rifabutin, because they're related to rifampin and lots of interactions associated with that. Okay, let's look at the third drug, is pyrazinamide. This is not used, universally. The first choices for somebody with latent TB is rifampin and isoniazid. And pyridoxine with isoniazid. That's routine. We layer on top of this, particularly if you're working with a TB clinic, usually a pulmonologist or infectious disease service manages a TB clinic for a region. They may add pyrazinamide based on certain protocols that are developed by the CDC. It is effective as a bactericidal drug, is associated also with some risk of hepatotoxicity. Luckily, usually these are reversible when you stop the drug. So they're pretty well tolerated generally. But, you add 2 or 3 of these potentially hepatotoxic drugs together in a cocktail against TB, at least we're monitoring liver function tests periodically for folks on these regimens. The fourth agent that's added, and typically this is going to be reserved for folks who are have active TB or are at risk for multi-drug resistant TB, is ethambutol. Ethambutol, as we go down this list, ethambutol is used less frequently than the first three agents are. And while it's used for TB, the biggest adverse effect we worry about that can be severe is optic neuritis that can be dose related. Often can resolve stopping the drug, but this can be a really serious adverse effect. And so folks on ethambutol really need to be steered toward their ophthalmologist and having maybe every 3-month ophthalmology evaluations while they're on ethambutol to make sure that there's not any changes in their vision. They're getting consistent ocular checks associated with that, and the ophthalmologist is evaluating for that. Finally, of the first-line agents, streptomycin, aminoglycoside, antibiotic, first effective against TB years and years ago. Associated, we'll talk about this, we talked about this a bit already, is ototoxicity, eighth cranial nerve damage, typically given by IM injection. This is sort of the last in line of the first-line treatments for TB, and many would consider streptomycin really a first line in the second tier of our treatments for TB. It's really sort of the bottom of the first-line interventions. The number of second-line agents, there are many of them, so we won't go into too much depth. Just be aware that they're either less effective or more toxic or a combination of those. But they're limited, but they are used for folks who have drug resistance to first-line therapies. And this might be, for example, in a population where multi-drug resistant TB is endemic. Usually a practitioner, particularly a TB specialist, pulmonologist, or infectious disease service will work with the CDC, contact the CDC to get updates as far as what is considered a drug-resistant TB area, how do we monitor for that, and then how you manage that. So one is para-aminosalicylic acid. It's a sulfonamide derivative, so if somebody is allergic to sulfa drugs, they would avoid this. We also have a few others, cycloserine, sometimes used. These are agents in practice I don't see very often. If I worked in a city or an area where the multi-drug resistance was common, probably would be seeing more of this. Other agents here, probably what really stands out of the bottom two categories is amikacin, kanamycin aminoglycosides, or the fluoroquinolones like ciprofloxacin or ofloxacin. Again, while they're used for some bacterial infections, they are used as second line for drug-resistant TB. So let's first look at treating, managing latent TB. These are folks where, for example, if you're doing a PPD or you're doing a blood test, we're going to evaluate a patient for their risk for TB. And these are folks who don't have active TB, but they have a positive conversion. And usually the classic skin testing, PPD, 5 millimeter in duration, and they are a higher risk for TB based on their contacts, or they have coexisting HIV or immunosuppression. Or if their PPD is 10 millimeter in duration and they have a moderate risk like their immigration status or the history of IV drug abuse, or they've been residing or employees of a setting where there could be higher rates of TB, or if anybody who has a PPD greater than 15 millimeters in duration. Those are the folks for whom we're going to look at treating them, and the protocols we're going to look at in just a minute. But keep in mind that we only test for TB if you're going to do something about it. So the issue is anybody who works in a healthcare setting, you're going to walk into, you work in a hospital, work in a nursing home, work in a clinic, you are going to have to be tested for TB. And usually that's on initial screening when you come into the organization, they'll test for TB. That might be a blood test if it's very low rates in your area, or it might be the skin testing if the rates in the region are higher. Those are all governed by recommendations from both the regional public health departments as well as the CDC. But if you're going to test somebody, you have to be willing to treat them if they rule in for latent TB. So the protocols we think about with TB drugs, you also have to think about what are some of the drug interactions when you start some of these therapies. We'll talk about these, which ones we pick and when, what the regimens are. But you have to think about what some of the interactions are. The TB drugs interact with lots and lots of things. So assume that you need to look at all the meds they're starting and stopping before they come see you, while they're seeing you and once you stop the antituberculin drugs. Or if they're your patient, but they've been seen by the pulmonologist and started on these therapies, you need to look at these interactions as well. So we'd see a lot of different issues here with different drugs associated with, depending on the agent, the antitubercular agent, when we see higher or lower levels or toxicity of a number of common drugs you'll see in practice. This is a very partial list, and so recognize this list is partial for isoniazid, for example. And then rifampin drug interactions are dramatic. There are many of them. And what you'll see is most of the levels of these drugs go down. Why? Because rifampin increases the metabolism of many of these drugs. And so, again, you want to run a drug interaction checker. If a patient has TB and they're HIV positive, then you want to be also careful about how you sequence their antiretroviral therapy with their TB therapy. And so you also want to look at avoiding rifampin or rifapentine if they're on certain HIV meds. And suffice it to say that most clinicians will defer the specifics of treatments of TB and their HIV to the specialist who's managing either with HIV or the specialist in the TB clinic or both of them. But there's this particularly sequencing that really needs to pay attention to, and which agents and paying attention to the interactions, particularly with the rifampin or the rifampin derivatives.